Welcome to Advances in Allergy and Asthma. This webinar series helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. It is presented in partnership with the American College of Allergy, Asthma, and Immunology. This is Sally Schessler, Director of Education for Allergy and Asthma Network. Today, I'm pleased to introduce Dr. Tanya Elliott, who will speak to us today about telemedicine. Dr. Elliott is an expert in telemedicine and digital health, leveraging connected care technologies to bring care to patients wherever they are. Passionate about the quadruple aim, she creates solutions to improve quality, efficiencies, access, and patient and care team experiences. She has a wealth of experience and unique expertise in driving strategy, operational excellence, and quality across a range of healthcare sectors, including health plan, health system, startup, and employer. If we could have the next slide. She is currently Chief Medical Officer of Virtual Care at Ascension, advancing adoption of virtual visits and remote patient monitoring across the care continuum, and developing new care delivery models for chronic disease management, behavioral health, and hospital-level care at home. Ascension is one of the largest healthcare systems in the country, with 150,000 associates and 40,000 providers at 2,600 sites, including 150 hospitals in 20 states. She served as a Clinical Solutions Medical Director at Aetna, a CVS company, supporting development of digital engagement and behavior change strategies for women's health, virtual primary care, and cardiovascular disease, and as Chief Medical Officer of EHE, a 106-year-old nationwide preventative health and wellness company, where she developed a novel, evidence-based preventative care model that leveraged a suite of digital engagement solutions to keep employees productive, healthy, and up-to-date on age and risk factor-based preventative screenings. Dual board certified in internal medicine and allergy and clinical immunology, Dr. Elliott embraced telemedicine first as a physician, then as medical director of Doctor on Demand, developing the nation's first fully employed nationwide virtualist physician workforce. In 2019, she was named Medical and Marketing Media's Top 40 Healthcare Transformers of the Year. She currently chairs the Technology Task Force for the American College of Allergy and Immunology, as well as the American Academy of Allergy and Immunology, and is a mentor for Stanford University's Masters in Clinical Informatics program. She has published multiple peer-reviewed journal articles on direct-to-consumer healthcare delivery and implementation of virtual care into clinical practice. She serves regularly as a healthcare broadcast media expert, regularly featured on top shows including Good Morning America, Rachel Ray, Dr. Oz, Dr. Phil, The Doctors, and CBS This Morning. Also, I just would like to mention that Dr. Elliott has nothing to disclose for this presentation, but she does have one disclosure that would be that she gets an honorarium for speaking from Teva. So Dr. Elliott, thank you for being with us today. We're looking forward to learning something new from your presentation.
Thank you so much for inviting me to speak. You know, telemedicine really took off like wildfire. You know, I went from being a fringe doctor that was delivering this, this digitally enabled care, and people didn't really quite get what I was talking about until COVID hit and all of our doors closed, and virtual care was the only way in which we could deliver care to our patients. And now fast forward, as we are experiencing some additional hurdles and challenges as it relates to COVID, but in a post-COVID world, what happens to virtual care? How do we take all of the learnings, the optimization of workflow that we painstakingly went through, but really learned how to effectively deliver virtual visits to our patients? How do we take that and then embed it into the way that we longitudinally deliver allergy care? How do we continue to promote and recognize the value of virtual visits, both the synchronous video visits, and then also I'll touch upon opportunities within the sphere of remote patient monitoring and remote therapeutic monitoring. And how do we also make sure that we're staying up to date with the changing telemedicine regulatory landscape as well? So first, let's talk about the continued value of virtual care. This is a study that was recently, just within the last week, put out by McKinsey. When I first started talking about virtual care 5 or 6 years ago, it was anticipated to be a $25 billion industry. Today, it is anticipated to be a $250 billion industry. Behavioral health is still the leader in virtual visits. It's something we learned during COVID. It really took off, and you'll see that even today, as of June 14th, the majority of visits for virtual for telehealth are behavioral health encounters. And I just highlighted visits to a specialist, so we're at about 12% of total visit volume for visits to a specialist. As an allergist myself, I've seen 7,000 or 8,000 patients through video. I really do believe that there's tremendous opportunity to deliver longitudinal care that is effective for food allergy, chronic urticaria, allergic rhinitis, and asthma through a hybrid care model that's a little bit in person and a little bit virtual. And we've talked about a number of different use cases, like your patients that are maybe going for a routine shot checkup every 6 months, and whether or not that could be conducted through a virtual visit, or ways in which virtual is an incremental value add to the way in which we deliver asthma care. One of the things we've learned is that asthma home visits during the pandemic that were conducted by nurses were able to be effectively conducted through virtual means. So think about the opportunity to scale a home environmental assessment for your asthmatic patients, and think about ways in which there's incremental value add for your patients for virtual care. For things like allergic and atopic dermatitis, chronic urticaria, tremendous opportunity for asynchronous encounters and having your patients upload photos and videos and being able to track their progress over time. If you think about it, it's an enhanced care over your subjective recall of how you think your patient may have looked the last time that you saw them, whereas with the photo upload, you actually have proof. Or what about the patient who has an allergic reaction that disappears within 24 hours? Wouldn't it be great, instead of taking a telephone call overnight, you're able to connect with them through a video visit and truly with your own eyes see exactly what was going on with that allergic reaction, as opposed to speaking over the telephone with effectively your eyes closed and then having the patient come in the next day when the rash has gone away. At Ascension, where I'm Chief Medical Officer of Virtual Care, until March of 2020, we had done 16,000 virtual visits, and as of June 30th, we've done 2.39 million virtual visits. So if there's any question in anybody's mind, virtual care is here to stay. So now I want to go into a little bit more about the virtual care myths, because a lot of this is dispelling myths. We hear all the time, well, maybe patients just want to come in to be seen. They don't want a virtual visit. And I challenge that question because, who really would prefer to, and it's all about the way the question is asked, but who would prefer to take time off of work, miss a day of activities with friends or family, miss a day at the mall, miss a day of playing tennis, golf, whatever, to sit in a doctor's office where the average time end to end for an appointment is about 4 hours, to wait to be seen by a doctor in person, where the doctor has a conversation with you, and essentially the same exact care could have been delivered in 10 minutes with a click of a button from the comfort of your home. But it's all about the way in which we phrase up these types of questions, and all about these kind of perceived barriers. So I want to take a few minutes to just go through a couple of myths and help to dispel some of those myths around virtual care. So myth number 1, patients feel more satisfied with an in-person visit versus a virtual visit. So something that's important to note there, and I'm just going to go back for a second, in patients feeling more satisfied with in-person versus virtual. There is still this perception around doctor knows best. So if we as physicians make patients feel like virtual is this fringe care, or, oh, I guess you could do a virtual visit, oh, but I'd rather see you in person. What I challenge doctors to do is make it okay for patients to have a virtual visit. Offer proactively that you schedule them for a virtual follow-up visit. Tee that up for them. Patients, a lot of times they want to please the doctors, believe it or not. And so if they think that they're doing something that isn't quite right, they may think, oh, well, it's not the best care, or I'm not going to be as happy, or it's not as good of a visit. So really think about the way in which you message virtual visits with your patients, and then also make sure you're understanding how your staff is talking about virtual visits with patients. Because when you actually survey the data, 86% of patients surveyed felt more satisfied with their provider and/or health system because they can access virtual care visits. So if you think about from a patient retention play or patient acquisition play, patients are now going to ask and they're going to select their doctor based on whether or not virtual visits are an option. And that's just going to be the wave of the future. Half of patients said they would be willing to switch doctors if they had virtual care visits offered to them on a regular basis. And at Ascension, over 2,800 patients who were surveyed, 95% were satisfied that the virtual visit met their needs and expectations. Myth number 2, virtual care is only useful for patients with low acuity needs. That's absolutely a myth. The truth is that was how virtual care was pitched. That's how telemedicine was productized. The company Doctor on Demand, when we launched it, was click a button, get your issue solved within 3 minutes. That was the value proposition. So that's all about marketing and messaging. It's not about how virtual care can truly be leveraged for longitudinal care delivery. And again, if COVID taught us anything, it proved that we can have great relationships with our patients longitudinally, and virtual care just may be one way in which you see your patient. So here's a breakdown at Ascension of the virtual visits that were done by specialty, and you'll see across the board 54% of primary care visits were conducted virtually, 23% of specialty visits, and the top chronic conditions were the top conditions treated. They were not the virtual urgent care type one and done type of conditions. These were visits that were done for patients to receive continued care from their doctor for hypertension, behavioral health needs, diabetes, ADHD, hyperlipidemia. So, if you think about your patient with allergic rhinitis that you may start, you do a physical examination that first visit, and then you want to see how they're doing, how their symptoms are doing at 6 weeks. Consider having that be a virtual follow-up visit and administering the rhinitis control test in advance of that encounter. So maybe think about shifting this arbitrary requirement that a patient comes in every 6 weeks or every 12 weeks to say, ask yourself the question, well, what if I could only see my patient in person once a year, but I could ask my patient a question every day? What would care look like? What if I could see my patient through virtual modalities and scheduled appointment multiple times per year? So just think about different ways in which we deliver care and break those models, and then just break those habits. And then think about ways in which you can measure success and prove to yourself that your patient's outcomes improve. The other thing I'll share with you is that at Ascension, we've had 50% fewer no-show rates for virtual visits than we do in person. So if you're struggling with no-shows or cancellations, that's another way in which you can leverage virtual care to improve patient adherence and improve patient access. Myth number 3, you don't get the same attention from a clinician virtually as you do in person. So virtual visits closely mirror the in-person clinician experience, again, without the hassle of taking time off of work. But if you think about it and you go through, so what do you do? Ask yourself, what do I do in a visit? Now, obviously, you're not going to give your patients allergy shots through a video visit, but you can certainly do chronic disease management. So think about what you do. You take a history. Can you take that history through in person or virtual? Yes. Physical examination. We've got great physical examination videos that were put together that walk you through how to conduct a physical examination through video. You can't do everything, but you can certainly do a number of things. And you also want to consider for your patients who you do want to listen to their heart or lungs, that the patient can buy a stethoscope at Best Buy that's virtual and can connect and allow you to listen to their heart and lungs virtually. So for patients with chronic conditions or those that are high risk, you can kind of get them set up with a virtual stethoscope or otoscope in the home. It might cost a couple of dollars, but if you think about it, that average over time and the ability to be, potentially avoid an ER stay because you're listening to your asthmatic patient's lungs from home and you can make that determination, there's real value there. Lab or imaging orders. If you're conducting a virtual visit and you're using a secure platform like Zoom, you're documenting in your existing EHR. So you can place orders and send patients to quest their LabCorp just like you would do in the brick and mortar office. You could just, from their home, you save them a visit to the doctor's office and you just send them straight for their lab. Same thing with medication reconciliation, ordering medications. Conducting vital signs, depending on what those vital signs are. We have videos talking you through how to evaluate respiratory rate, how to check pulse, and patients can purchase a blood pressure cuff for about $10, and you can just walk them through how to check their blood pressure. So I want to now talk about why virtual visits, and I kind of mentioned some of these things, but meeting patients where they are in patient experience and making your practice be the optimal practice that patients want to come to. So for a patient acquisition and retention perspective, avoiding unnecessary in-person visits, this is just as important for patients as it is for a clinician. So as much as I educate doctors on think about whether or not you can get the same amount of information and what's going to change your management and whether that visit could be done virtually or in person. From a physician experience perspective, you could work from home. You don't always have to be in your office. So if you want to think about the business model around having more procedure-based care in your office, you're going to have higher reimbursement for that procedure-based care in your office, and then offload all of those routine visits to virtual. Then, especially if you're cramped for space, you can have, multiple doctors taking up those, who are doing procedure-based visits in the office, taking up the exam rooms, and then have your other doctors working from home. Also an opportunity for you to have expansion of office hours without, you could do, allergy office hours during allergy season on Saturday morning from 7 to 9 a.m. and you could be working from home doing those routine follow-ups and check-ins. So lots of value there. And again, from a physician quality of life and physician experience perspective, doctors really enjoy being able to work from home 1 or 2 days per week. And especially with COVID, we're, coming back into this fall, whether children are going to be back in school, it's an opportunity for, the parent who's a physician to continue to work from home, but still be able to see their patients. And then operational visits, again, I mentioned this before, but we've seen, again, 50% fewer no-shows for virtual visits versus in person. So the other thing you may want to consider is if you know your patient has challenges, maybe you screen for social determinants of health challenges like employment insecurity or transportation related issues or childcare issues, you may want to proactively offer them a virtual visit. You know the patients that are going to be at risk for not showing up. So why not proactively offer them an alternative so they don't have to miss work in order to come in for an appointment. Now I want to talk for a moment about the changing regulatory landscape, and this is really important. Most of the commercial payers had telemedicine policies in place pre-pandemic. So we hear this a lot at Ascension. We've been hearing that providers say, oh no, the PHE is expiring, or my state PHE is expiring. So that must mean that telehealth is going to go away and I'm not going to continue to deliver care through telehealth. And that's not the case. As I mentioned, most commercial payers already had a telehealth policy in place prior to the pandemic. So there are a few things that may change, and I'll walk you through those things. But generally speaking, telehealth is not going to go away. Reimbursement and coverage is not going to stop. So let's first talk about the federal public health emergency. So the Biden administration has already announced that they're going to extend the PHE through at least the end of 2021. And they also acknowledge that they need to provide at least 60 days advance notice for any changes. So for anyone who's seeing Medicare patients, you do not have to worry. All the waivers are still in place and they will continue to be through at least the end of 2021. There are a number of bills related to telehealth in Congress as we speak. The Connect for Health Act is probably the biggest one. We at Ascension continue to advocate for payment parity, for removal of originating site requirements and coverage for telephone. So I don't have a crystal ball, but if I had to guess, my guess would be that the originating site requirements will go away. And what we continue to advocate for is, if you don't believe us, then just give us more time. And we're advocating to continue to have those flexibilities in place through the end of 2023, at least, to give us more time to put data together so that we can prove out the value of virtual care. But I would encourage you to be proactive, and American Telemedicine Association has a number of petitions in place, and make sure you reach out and be proactive with your states around assuring that telehealth continues to be covered. But for right now, there's nothing to be concerned about. The federal PHE and the telehealth waivers attached to that will be in place through at least the end of 2021. Some states allowed their state-specific PHE to expire, but most of those states also had already extended telehealth flexibilities, either on a permanent or a temporary basis. So, Medicaid can be very complex, and I would encourage you to talk with your, local leadership and do some research yourself. But generally speaking, just because they let their PHE expire, just decouple that in your mind from telehealth, because a number of these states have already passed bills to extend telehealth flexibilities. For commercial insurances, as I mentioned already, the majority of states, they have a commercial coverage law. So it would be against the law for a payer to say we're no longer reimbursing for telehealth anymore. And if you think about a payer that's a national payer, they're not going to have one provision in place for one state and then a different one in another state. That's too complex. So if 40 states already have some sort of telehealth requirement, a coverage requirement in place already, then the likelihood that they will revert on all that, it's against the law to do that. And again, on originating sites, there really doesn't appear to be any movement around reinstatement of originating site requirements. So I just want to show you this map. So these are the states that are in blue that there was a requirement to cover telemedicine services pre-pandemic. So when people say, oh, the payers are going to roll back, they're not going to reimburse anymore, they can't. It would be against the law to do so. And then since the pandemic, 5 additional states have come on with their state-specific requirements. Now, the difference is, there's a difference between a law that says you can cover telehealth services, meaning insurers have to pay for telehealth, and then insurers have to pay with parity. And parity means you'd pay at the same rate as you would pay for an in-person visit. So 10 states have that parity requirement, where the same amount that you're reimbursing for in-person, you would have to reimburse for virtual care. The remaining states say, hey, you have to cover telemedicine services, but we're not going to tell you how much you're going to reimburse for. As it stands today, there haven't been any payers who said that they're going to reimburse for less, but I mentioned a couple of things may change. If I had a crystal ball, I would say it's possible that virtual care may be reimbursed at slightly less than in-person rates. So this is where you have to think about, where telehealth could just be additive to the work that you're delivering. Like you're doing your on-call, and instead of doing a telephonic kind of on-call, you convert that over to a virtual visit, or you offer early morning virtual visit hours from 7 to 9 a.m. Or you're recapturing no-shows and cancellations. You wouldn't have obtained any revenue anyway because those patients weren't going to show up. So think about it from that perspective, that it's additive. The other thing that I will say is that I absolutely are going to need to be back on a HIPAA compliant platform. So you might as well be on it now if you're not already. That's one thing. And then the last thing that will likely revert back, or 2 other things likely to revert back. One is the state licensure requirements. So if you're seeing patients who physically live in a neighboring state and you're not licensed in that state, you should explore obtaining licensure in that state. So New York, New Jersey, for example, these border states, the best route would be to just obtain licensure in those additional neighboring states. The last area where there might be some changes or rollbacks would be around what types of services are covered. This probably doesn't impact allergists because routine E&M codes were always on the telehealth coverage list. But there are certain things like physical therapy, operational therapy, maybe some audiology services that it's still unclear as to whether or not the expansion of the telehealth service list will stay as is, or they may go back to what was originally and initially on the reimbursement list. But as I mentioned, the majority of things that we see our allergy patients for, the standard E&M codes, those codes will be unaffected and they will continue to have coverage. So now I'm going to move on to workflow and implementation. So hopefully you're still doing virtual visits, but if you haven't done it already, you really want to think about kind of memorializing your workflow. And then again, as I said earlier, really thinking about how your staff talk about virtual visits, when they offer virtual visits, how they message it to patients, what your marketing materials look like. So there's an opportunity now where our patients are primed and they want it and they're looking for it, to rethink some of your existing workflows. So I put together this framework for our practices at Ascension. It's ready, set, go. So ready, you want to engage and prepare your office and your staff to schedule virtual visits and also set your schedule. You want to engage and prepare your patients for virtual, and then you want to do some planning before, during, and after the visit. And then lastly, we'll talk a little bit about goals and how to measure and maintain success. So in terms of preparation for virtual visits, you want to make sure you develop educational materials for clinicians and staff. You know, we're creatures of habit. We're used to our existing workflows. We figured out, you know, how to get the maximal number of shot patients in. We figured out, you know, our allergy testing patients and what those schedules look like. Now the next layer to add on is where do virtual visits play in, and what is your schedule going to look like, and then making sure that you educate everybody in your practice on it. You want to make sure you have a HIPAA compliant platform in place. My recommendation is just purchase something inexpensive that allows you to do a secure video visit connection, and then do everything else in your existing systems, your existing schedule. Just pick a color and make the color blue your virtual visits, and your existing documentation. So I would not recommend finding a platform where you would kind of document and do everything for your virtual visits separately from your in-person visits. Hardware, you want to determine if your staff or doctors need a webcam, a headset. You also want to make sure if you want to allow staff to work at home, that they have the proper equipment at home, they have the proper lighting as well. And then locations is just making sure that if you are going to be conducting, let's say, virtual visits in between office visits, that there's a private place to conduct those visits. And then thinking about how to accommodate your schedule. So you could do it a couple of ways. One is you can just create a virtual visit schedule block during the office day. So you show up at your office, and from 9 to 12, you're doing virtual visits. And then from 1 to 4, you're seeing patients in person. You could do it on the fly in between in-person visits. Some doctors like this, other doctors don't like having to switch back and forth, and they would prefer to have it in blocks. You can think about full days of virtual care from home, and full days of in-person, and shifting it that way. And then thinking about, again, expansion, office hours and non-traditional hours like weekend and holiday. And that's really nice if you want to be able to provide same-day visits, especially during allergy season. Like I said, you can, think about a compensation model where maybe you reimburse a physician to be available on call for virtual urgent visits, same-day visits from 7 to 9 a.m. on a Saturday morning. And then it's a sort of base rate, and then you can pay them additional for every patient that they see, for example. And then, thinking again, when you are doing virtual, where are the staff and clinician working when virtual visits are being done? And think about, paying for an office staff member to be physically in the office versus considering, doing virtual check-ins for your patient where that staff member can be working from home. The other thing is you want to prepare your staff. Again, I cannot express enough the messaging that especially if you hear, oh, the patient just wanted to come in, my guess is that the way that was messaged to the patient was suboptimal. And if you actually beta test different ways in which your staff is scripted and communicates with the patient, you'll get different outcomes. So you want to make sure your staff is clear on how virtual visits work. You can always use a checklist, and I always say this to everybody, is there's no wrong reason to see a virtual visit. We hear a lot, oh, well, what's appropriate and what's not appropriate for virtual. And what I say back to them is, when is it inappropriate for a patient to have a face-to-face conversation with their doctor? Worst case scenario, the patient is gone to the wrong site of care. And you know what, that happens in the office too. I'd rather them go to the wrong site of care than no site of care. So I'd rather them call me up, tell me that they're short of breath, me see that they're using accessory respiratory muscles for breathing, and direct them to the ER. Because otherwise, either they would have had no care at all, or they might have shown up in my office and waited in my office for 2 hours, and then I have to rush them to the emergency room. So I do challenge people to tell me, when is it wrong or inappropriate for a patient and a doctor to have a face-to-face conversation? Now, which appointments require in-person visits? Well, vaccines and procedures and things that are hands-on would require an in-person. So engaging patients, so patient outreach. Offer all patients that are calling to cancel a virtual visit, offer them a virtual appointment alternative. Call all of your no-shows to rebook a same-day virtual. After 15 minutes, patient hasn't showed up, call them up. If you get them on the phone, say, hey, you want to have a virtual visit now. Your doctor's already available. Call patients who are lost to follow-up, those who haven't been seen in greater than 12 months. This is more for, for your older patient populations or if you're doing some primary care, but annual wellness visits are a great use case for virtual. Or patients who have outstanding gaps in care. Maybe you haven't done smoking cessation evaluation for your patients or anything related to meaningful use, and you maybe just want to schedule a visit with the patient to just kind of walk through making sure that they're up to date with their medications, that you're, up to speed on how their condition is. Marketing, if you have a local marketing team, you can work with them to create a campaign for all new doctors. It's a really nice way to announce that you have a new doctor and that doctor offers virtual and in-person visits. If you have a website, ensure that it promotes virtual visits and also that you're able to schedule virtual visits online. New patients, offering new patients virtual visit for that initial consultation where you could do that evaluation. And that's particularly good for specialists because I think sometimes, and especially if you're in value-based arrangements as well, but sometimes we say, hey, you know what, this patient really doesn't need me, they need a rheumatologist, or maybe they need a dermatologist. So, for those patients, especially if they're complex patients and you want to spend a lot of time with them, maybe it's an immunodeficiency consultation, why not have that initial encounter be a virtual encounter? You could still send them for their laboratory tests or what have you. But it's perfectly reasonable to offer for new patient consultations through virtual visits. And again, make sure you use templated communications and really think about how you message a virtual visit. If it seems like it's a product, like get your virtual visit today, people are going to think that it may not be the same type of care that they get from their quote regular doctor. So you want to make sure that the messaging is really integrated into whatever your brand is for your practice and not just this carve out, access play for virtual visits. Again, same thing. I can't emphasize this enough that you really want to train and script your staff. So, you can offer virtual visits for routine follow-ups, empower your staff. You can have a little checkbox or just write on the, to your staff members, schedule this patient for virtual. So then that staff member knows the staff member is not placed in the position of, is this appropriate for virtual? Is this not? Oh, I guess I'll just schedule for an in-person follow-up. So you can direct your staff and then the staff is empowered to say, great, Dr. So-and-so wants to see you for a virtual follow-up visit in 6 weeks. How's that? Virtual alternative for cancellations. We can keep your appointment by making this a virtual visit with your doctor. Would you like for us to go ahead and do that and you'll see your doctor now? So you want to just make sure that you're, again, messaging it in the right way. And again, online scheduling. So when you're actually seeing the patient, a few things to take into consideration. If you have a population who's non-English speaking, you want to determine if translation services are needed. Nothing fancy here. It could be a telephonic translation, and you can just have that person available on speakerphone as long as the volume is loud enough. You want to remind patients to check their technology prior to the visit, like their browser setting, camera and microphone access. Some practices will actually do this with the patient when they're on site. So as the patient's checking out and they're scheduled for a virtual follow-up, they say, hey, I'm just going to send you a quick test virtual visit. So you just click this video link. It's going to come through in a text message. Great. Looks like you're all set. Other people will other practices call patients the day before to make sure it's appropriate. And then lastly, some of the technology solutions, while the patient is waiting to be seen, will actually walk them through the steps of how to test their microphone and the camera and troubleshoot. If you have a vendor platform, you want to also just make sure that you have a local IT person that's dedicated. And by local IT, I just mean training your office staff on the routine challenges as it relates to virtual care, because it's virtually impossible to get IT support from a vendor on the phone. So you just want to have an office staff with maybe a one-page cheat sheet. Hey, restart your computer. Hey, make sure you're connected to Wi-Fi. Check your upload and download speeds. Very straightforward troubleshooting tips. Really helpful to just have somebody at your practice who's knows how to do that basic troubleshooting. So when you're operationalizing the visits and the things to things to take into consideration, if you're doing an outgoing call to patients, you may want to determine if you need a private phone number. Google Voice, for example, offers that. Doximity Dialer is another one. Patient forms and signatures. So if you are going to be using this for new patient acquisition, or you want to get consent forms over to a patient, you want to make sure that you can get those forms sent over. electronically and then uploaded electronically. It's sort of like if you're going to be doing virtual, it should really all be virtual. So it'd be kind of silly to say, okay, I'm going to see you virtually, then you have to print out your forms and drop them off at the office. So there are lots of solutions out there, like Adobe Sign, for example, that allow patients to complete all their forms and then upload them. Send a visit link to the patient and determine if they want that sent to their cell phones, if they want it sent to an email, if they want it to send to a friend's or family cell phone number. Sometimes maybe a patient doesn't have a smartphone, but maybe a friend or family does, so you'd want to just coordinate that with the patient. And then figure out the communication and the connection between the clinician and staff. So for example, you can have your MA connect with the patient first, make sure they're on the line, do an intake, initial history, and that's like the same thing as like rooming your patient in the office, and then send the doctor a link when the patient's ready to be seen. And you could also indicate in the EHR that the patient's ready to be seen, and then the MA would just drop off the call when the doctor is connected to the patient. And so if you're doing that, you want to just make sure that whatever technology platform you use allows for the addition of multiple participants. So the day of the appointment, and again, these are being very prescriptive around this because it is a new workflow, and we want to acknowledge that it's a new workflow for staff. But if you want to, figure out how to kind of continue to embed virtual visits post-COVID, you really want to take into consideration actually mapping out the new, these new workflows and making sure that all of your staff members are trained. But essentially, you have the patient virtually checked in or roomed by a medical assistant or your nurse. You conduct the appointment, everything is documented in your EHR, you discharge the patient, and when you do that, you can also send a link right back to that nurse and say, hey, patient is ready to be checked out, and then the nurse pops right back onto the camera with the patient and then can coordinate follow-ups. And then just make sure that your office manager is aware of the billing for virtual visit, and then make sure that the visit note clearly states that the patient was seen via video visit. So then goals, how do we measure success? How do we make sure that this is here to stay? So one thing you would want to do is set goals. So maybe you want to improve gap in care closure, reduce your no-show rates, maybe you want to grow your practice. Establish frequent staff huddles. So you want to identify opportunities to achieve those goals and talk about some of the challenges, what's working, what's not working, and then also discuss patient feedback. And that could be in the form of a survey, or it could be in the form of anecdotal feedback, like, hey, patients keep saying they just want to come in. And again, that's when you double click and say, well, walk me through exactly how you message this to the patient, exactly what's going on there. And maybe it is a patient. There was a study done with the Medicare population that showed that some patients are lonely and they have social isolation and they do like going in to see their doctor. But for the most part, patients do prefer to be seen, virtually when given the option, and it is equivalent option. Develop care models. So, here's an opportunity to, especially if you're in a large practice, to go to payers, with chronic disease management models of how you're going to manage your asthma patients, bundled payments, episodic payments. And then you want to track progress. So, depending on your EHR, you want to pull summary reports, you want to pull together monthly dashboards so you can actually track whether or not you're seeing a reduction in your no-show rates, for example. Or you could look at the percentage of patients that call for same-day appointments that get converted for virtual visit versus same day in office. So now I'm going to pivot and talk a little bit about virtual care and how it's not just video visits. And virtual care is an umbrella term for a whole spectrum of connected care services that I'll show in a moment. But remote patient monitoring, which has specific CMS codes attached to it, and now new CMS codes under remote therapeutic monitoring. This is sort of the next wave of the future. So think about it, telemedicine is already here. That's the synchronous video visit, but this is the 2.0, remote patient monitoring and interacting with patients through technology in between routine episodes of care. This is the wave of the future, so we really need to, and asthma care in particular, getting a lot of attention. This is really where we need to start to focus our energies. So when you think about virtual care, it's a spectrum, and I think it's really important. We put together this framework at Ascension, and it's been really helpful for level setting for our leadership and our doctors and even non-clinical staff to kind of understand when you're talking about virtual care, what are we talking about, and recognizing that there are CPT codes attached to these various services. So start on the far left, it basically goes from the lowest resource intensity to the highest resource intensity, but lowest resource intensity, communication technology-based services. So that's what I was saying before, asynchronous communication, where your patient uploads a photo or a video, to a patient portal, and you review that. That's a billable service. The other group of codes are around e-consultations or specialist second opinions. So specialist second opinions are great for allergy specialists. So this would be a way for you to develop really good referral relationships with primary care doctors and pediatricians, and potentially save patients a visit to you, or get a patient worked up in the way that you would like them worked up in advance of an encounter. So an e-consultation is essentially a provider-to-provider interaction where the consulting provider, the primary care doctor or pediatrician, will ask you, the allergist, a clinical question, and then gather the relevant medical records and send them over to you. You would review those records and you can provide a written report back, and that's a billable service. Or you can bill based on time if you provide a written report back and have a conversation with the doctor. So another way to think about this is a formalization of the curbside consult that we get a lot of times. But this is really great for, if you patients that you see a lot that are with rare conditions, for immunodeficiencies, sometimes for food allergy evaluation, or idiopathic anaphylaxis, mast cell disorders, things like that that are rare. But even for bread and butter stuff where the pediatrician or the primary care just wants a second opinion on how the patient is being managed. So again, those are billable services, e-consultations, and a great way to develop relationships with your referring providers. There are certain criteria associated with it, like you can't see the patient in person within, I believe it's 7 days or 14 days, so it would need to be spaced out, and a number of other things associated with it. But it's really clear, and it's a great way, again, in which to sort of have a new service line for your patients, and for referral partners. Synchronous video, we talked all about it. That's our telemedicine services that are provided. And then there's a whole spectrum of remote patient monitoring. And that's everything from patient surveillance, which is where we're monitoring patient self-reported data. So maybe you're checking in with symptom scores every day, or you're regularly administering, a rhinitis control test or asthma control test, but on a daily basis. Connected devices, that's near real-time monitoring of data that's coming from an FDA-approved device. So, maybe it's a glucometer or their biosensors. There's so many devices out there, and there's a number out there for respiratory disease that track respiration rates and things like that. And then facility patient monitoring. So this is ICU level monitoring and hospital level monitoring that's conducted remotely. So remote therapeutic monitoring codes have been they're now on the Medicare fee schedule for 2022, and that's the patient surveillance. So that is the self-reported data, the symptom management data that's being tracked in real time, whereas the existing remote monitoring codes are for device data through a connected device. So why is remote monitoring important? So again, it involves collection and analysis of physiologic data. It's used to develop and manage a treatment plan for either an acute or chronic issue. So it's helpful because, so I'll give you an example of it. So if you're monitoring a patient's respiratory rate of someone with COPD, you would give them the device, they would check their respiratory rate and oxygenation, and then that information would be uploaded to a monitoring dashboard. All kinds of dashboards that are available. You could have a nurse be responsible for actively monitoring it, or you could do a monitoring of exception where the patient's entering that information and then you or your nurse are only alerted if there is an abnormal value. What it allows is for you to evaluate somebody who you're concerned about clinically, so a critical alert, and you're getting information in near real time. So maybe you're on the fence about sending somebody to the ER and you just want that additional piece of monitoring for them. And then it also allows you to trend and track data over time. Maybe you're not quite sure how somebody is doing with their asthmatic medication. You just want to kind of track their inhaler usage over time, for example. So that would be something that can help inform your broader treatment decisions. We believe that remote monitoring is going to be table stakes for value-based arrangements in the future and reduce total cost of care. And again, it's really something that's right around the corner. And for respiratory diseases in particular, there's lots of research going into it. So I would really, have you all start to think about ways in which you want to incorporate remote patient monitoring technologies into the routine way in which you deliver care. So just like we were solving for the telemedicine workflow, now we need to solve for this information that's going to be coming to us in the white space, in between routine episodes, routine visits, and how we're going to get that just-in-time information in the hands of the treating physician to improve and inform treatment decisions. So this is just a very high-level framework. So number one is not all patients are the right candidates for remote patient monitoring. So you really want to make sure that you identify the right patient populations for a program. So maybe you want to look at all your high-risk asthma patients or your asthma patients that are frequently showing up in emergency rooms. The second is clinical intervention. So the care team that's going to be involved in this care likely will involve a nurse who will kind of double check that the values are truly those abnormal values, tied to a physician who's going to be the one that informs and makes the treatment decision. Most of the remote monitoring programs that exist today really are associated with like health plans or employers, where it's just like this nurse monitoring team, and it's really disconnected from the way in which doctors deliver care. The wave of the future is a hybrid care model, where a little bit is virtual through telemedicine, a little bit is in person for procedure-based care, and a lot of it is this technology-based interaction with devices and patient self-reported data and information. And so we really have to set ourselves up and be prepared for this new way in which there's going to be an influx of information. So get involved early, get involved now, start to think about being involved in clinical trials with any remote monitoring devices, become a medical director for companies that have remote monitoring platforms, and be at the forefront so we could actually inform how a number of these programs and devices are actually designed and developed. The third tenet of a successful program is really outcomes and clearly defined success measures, and then technology, and having the right technology that's going to enable scale, a technology that integrates into your existing workflows like your EHRs, the technology that allows for just-in-time information to be placed in the hands of the decision maker. And it seems like it's this whole new world of medicine, but the truth is we kind of have this in place for, let's say, a critical lab value, right? Quest or LabCorp knows which doctor to call if there's a lab that's out of range. So if you think about it in that context and you say, okay, well, maybe there'll be a couple more of those critical lab values. So let me make sure that I have algorithms and workflows in place so that I'm alerted for only the information that matters. But it can be a tremendously valuable tool for patients. And this is an industry that is continuing to skyrocket. And it's something that we need to be made aware of, and we need to start thinking about how we can integrate it into care. At Ascension, we've been doing remote monitoring programs since 2014. And so a number of large health systems are doing it. Most of the payers have programs, and there's lots of solutions that are out there. So this is the future, a digital formulary. So imagine that prescribing these types of programs are just as easy as prescribing a medication. And with a digital therapeutic in particular, there are outcome studies that show that patients that are on these programs have efficacy and outcomes just as effective as medications. So this is the wave of the future, where we need to get used to prescribing wearables, digital therapeutics, patient surveillance, patient reported outcomes, these devices and biosensors that stick on patients. Maybe we prescribe a digital coach. This is the way through. This is the wave of the future, and it's coming very quickly. So in summary, digital technologies in general have rapidly penetrated many aspects of our interactions with health, or with patients' interactions with their doctors, and this is going to be table stakes soon. So it's not just a novelty, but an integral way in which we deliver care to patients. It ensures patient engagement and timely treatment, and it can improve quality outcomes and total cost of care. And remember, when you're thinking about how you're going to incorporate remote monitoring and these types of technologies into your practice, you want to think about three customers: yourselves, the doctors, the clinical staff, as well as the patients. So where do we go from here? I would definitely recommend monitoring any policy developments and do advocate strongly that Congress and the administration take action to support ongoing access to care. Leverage your post-COVID telemedicine progress. Start to memorialize your workflows, especially as we're going through another wave and we may shut our doors down again. Make sure you memorialize some of those learnings and those workflows, and explore new opportunities for telemedicine and digital health in your organization. And with that, I'll end and I'll open it up for any questions.
Oh, thank you so much, Dr. Elliott. You've just shown us like a whole new world. But we do have questions from our participants today. The first one is, asthma is not listed in the top 5 chronic conditions for seeking telemedicine care. Why do you think that is?
I think that's a great question. In the top 5 conditions, at least from the Ascension data, it was from primary care clinicians, and part of it could have just been, skewing our patient populations that were being seen. One thing that comes to mind is that when we think about asthma patients, we really want to think about listening to their heart and lungs, which I do think is important. But I don't think there's any study that shows that you have to listen to their heart and lungs every 6 weeks, especially if you're administering something like an asthma control test. So whether it was our population that was skewed or maybe a little bit of trepidation, again, think about, how is this information going to change management? If my patient's asthma is well controlled, can I step up or step down a therapy without, listening to their lungs at 6 weeks, but maybe the next visit is an in-person visit. And again, thinking about sharpening our skills around the respiratory exam and asking them virtually, take big deep breaths, seeing whether they're using accessory respiratory muscles for breathing. And then the other thing would be to make sure they have a peak flow meter at home, which could be another objective measure. And then the last thing I'll just say about asthma care is really think about a different type of visit where you can do an environmental assessment of someone's home to identify maybe there are allergic triggers that could be making their asthma worse. Maybe you could have insights into the air quality of their home if they're in a very cluttered home. And again, we know that home visits for asthma work. So think about what are the things that are being conducted and assessed during that home visit, physically in the home, and see whether or not that can translate over to virtual.
Okay, thank you. Do you think the COVID-19 pandemic will make telemedicine visits a normal thing from now on?
I absolutely think that, and if it doesn't, then that would probably mean that our patients are getting care elsewhere, because Amazon Care is going to do it, or Doctor on Demand is going to do it, or patients are going to choose a digital first health plan where they're able to see a virtual primary care doctor. So, it needs to be a routine way in which we deliver care to patients. Otherwise, our patients are going to get their care elsewhere.
Okay, good point. Our next question from one of our listeners says, some doctors are offering telehealth visits over Zoom. Is my health information safe using that?
So Zoom does have a HIPAA compliant solution. So you would want to, it's a great question, and you want to make sure that they're using the HIPAA compliant version, but there is a Zoom for healthcare. So the answer is yes, but you want to just make sure that they're using the HIPAA compliant version, and then it is safe.
Okay, great. Next question is, do patients typically have to wait as long for their scheduled telemedicine visit like they have to wait in the office?
So that's a great question. So one is we see that wait times to get an appointment are much shorter when the practice is offering virtual visits. The second is, and it's a really interesting question about the waiting room. And so at Ascension, we actually created a proprietary video visit solution, and they're in development of a virtual waiting room. And I challenged the team, and they said, why are we recreating the thing that is the bane of patients' existence in a brick and mortar setting? So we don't want to recreate the same challenging experience where somebody has to sit in a virtual waiting room and wait to be seen versus waiting in an office waiting room to be seen. So as you're thinking about your workflows as clinicians also, and as patients, as you're kind of searching for the optimal practice, you do want to ask about that question about wait times. Generally speaking, though, I'll say that the wait times tend to be less for virtual visits, provided the technology is working effectively, and that's why it's important to always test your technology. That's one. And number two, the least original studies with Doctor on Demand, where we were looking at the virtual urgent care visits and what patients' tolerance threshold was for virtual, patients tend to get antsy and drop off after about 5 minutes. So if you think about that as a proxy for wait time, think about what the patients, now that a patient has traveled all the way in to a brick and mortar office, they're willing to wait about 30, 45 minutes before they start getting in a huff. But recognize that a patient's expectation of sitting around waiting in front of a computer screen with this new type of visit, after about 5 minutes, they're going to start to get upset. So overall, the wait times tend to be lower just with that metric, knowing that metric alone.
Okay, great. You pretty much touched on this before, but we have a question that says, will I be able to use telehealth for an after hours visit?
I think it's a great way in which to see your doctor and for doctors to be able to improve access for patients. If you think about it, the doctor, is on call, and then they get a phone call from, the on-call service, and then the doctor calls you back. What's stopping them from shooting a link to your cell phone to do a secure video visit instead of a phone call? So in my mind, it's a superior way to deliver care. From a clinical perspective for the doctor, they're on call anyway, and we know that actually putting your eyes on the patient can improve the care that we deliver, especially if it's an on-call doctor that doesn't know the patient and the patient is feeling sick. So in my mind, it should be standard of care that those after-hour visits that would generally be routed to telephone should just be converted to a quick video visit.
What I would think is, from a patient standpoint, that you would feel kind of, if you want to say, less guilty about, calling for a visit if you knew that they could do it from home. And I think that there would be really something there too.
Absolutely.
So, is there any data about how senior citizens feel about telehealth visits? Especially, the question is, do they have difficult hearing on a telehealth visit?
That's a great question. So when we look at sort of the Medicare data around virtual visits, 44% of the total virtual visits that were conducted in the first year of COVID were Medicare patients. So one of the myths we actually had in another presentation was a myth that telehealth is only for millennials or young people or busy moms. Again, that was the product. That was what we were marketing to. That was based on just an assumption, but there wasn't a reality. Medicare patients love virtual visits. For patients that are hard of hearing, that is something to take into consideration. What I would recommend for those cases where your patient is, you can ask those patients if they are hard of hearing, and I would recommend that a patient's family member be present with them during the visit to assist them, or even be conferenced in through the video visit. And I would also think about, what do you do for your patients that are hard of hearing in the office? Some patients that are hard of hearing, they may rely on reading lips. There are some telehealth solutions that offer closed captioning. So that might be, if you do have a high population of patients who are hearing impaired, you may want to explore closed captioning for those populations. So I think there are lots of options that can help support patients who are hearing impaired.
Okay, great. This is an interesting question. Is there a distinction between telehealth and telemedicine?
That's a really good question. And again, in another deck, I've got a whole list of definitions because it can get really confusing. So telemedicine technically is the synchronous audio-visual interaction between doctor and patient, or clinician and patient. So that's the synchronous video visit, the secure FaceTime, if you will. Telehealth is more of an umbrella term that encompasses more services than just synchronous encounters. So that also encompass, or telehealth or virtual care, they're often used synonymously. So that will also include the communication technology-based services or the remote monitoring services I mentioned before. That said, there is a telehealth services list that CMS has put out, and they are referring to telemedicine services. It should really be called telemedicine services list, but that's like currently what's on the list, and then that list got expanded during the PhD to include other things like physical therapy, occupational therapy, and what have you. And it's called the telehealth services list, but it's really referring to telemedicine. And then communication technology-based services like your e-consults or photo uploads or video uploads and things like that, you'll hear somebody say they're not on the telehealth services list. That's because they're not telemedicine synchronous encounters, and they have their own set of codes. So it's not that they're not covered, it's just that they have their own set of codes, and they're called communication technology-based services. So I know it could be super confusing. Hopefully that helps to address it.
I'm sure it does. Okay, we have time for 2 more questions. The first one will be, are other countries using telemedicine successfully?
Other countries are. In the UK, there's one kind of chat-based technology solution for virtual primary care called Babylon Health that's been very successful. I recently did a global webinar with folks from the UK and Australia, all of which have shared their experiences and successes for telehealth. I would say other countries internationally, they really do recognize the value, and they're really focused on the quality and proving out that telehealth can provide quality care services to patients.
Okay, great. And our last question is, how do I find out if my doctor offers telemedicine?
Ask and keep asking and keep pestering until they do.
Oh, sounds good. Dr. Elliott, this has been so helpful today. I totally appreciate all that you've had to share. Thanks for being with us.
Thanks for having me.
So for our listeners, thank you for joining us today. And at this time, please download the certificate of attendance from your control panel. If you have any difficulties, please email us using the link in your emails. Please join us on August 12th at 3 p.m. to take a look at sharing COVID-19 vaccine decisions with your doctor. This presentation will help you as a patient or in guiding your patients in that important vaccine decision. You can register for this webinar on our website at allergyasthmanetwork.org. Just go to the homepage and scroll way to the bottom and you'll see webinars. You can also view our recorded webinars on this page on our website. Visit our website for quality guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We're bringing you innovations in medicine so we can all work to breathe better together.